Good morning, everybody. It's really my pleasure to welcome you to the University of Pennsylvania, to the School of Nursing, and to Philadelphia. I think we have much to share with you, and we are just so privileged that you all are here with us for this conversation. In preparation for this meeting, I was asked to provide the committee with definitions. As we all know, when we're talking about special needs and populations, it is like definition soup. Health equity, structural racism, social determinants of health, culture of health, and it can be confusing. So rather than give you a list of definitions which you can apply to, what I thought might be useful is to provide a framework so that we could understand where these issues are and where they come from, and understanding some of the work of the committee. I don't know why. So the purpose, I think, when we're looking at addressing complex social needs is really thinking about how is it that we as a profession can advance health equity. When we think of equity, and sometimes that gets confused with equality, when we think about equality, it means that everything is the same. When we think of equity, what it means is an equal chance, a fair chance, and that can be applied to the health arena. Many of us talk about health disparities, which simply are differences that are associated and linked with economic, social, or environmental disadvantage. Health inequities are based on ethical judgments about differences. So I can feel bad that I'm short. That's a disparity. Is it a just disparity? I don't know. It depends on what the causes of that. I will say mine is genetic. But when we think about the disparities in smokers and their rates of death, is that it is a disparity, but is it an inequity? When we think about the lifespan of migrant farm workers who live to be 50, that's a disparity, but is it an inequity? Again, depending on what we believe about the causes. When we talk about health equity, it's the belief that everyone has the opportunity to attain the highest level of health. So this is the framework that I'd like to present. It was adopted from Castrucci and Auerbach. And again, talking about the individual impact and community impact in terms of addressing health disparities. So on the bottom line for this first component is taking a look at what happens in clinical care. And so we have the danger of implicit bias and also addressing healthcare disparities as we provide clinical care. So implicit bias is a stereotype that's inaccessible to conscious awareness and or control. And that does have an impact on how we interact with people who are different than us. Cultural competency is a strategy that has been used to try and mitigate that in personal interactions. We know from the work of certainly your committee member, David Williams, and others, that implicit bias and discrimination happen in healthcare settings, as good intentioned as we are, and they have adverse consequences for the people that we treat. As recently as 2019, a study was done on the mistreatment of women during pregnancy and labor, where women of color and low SES reported disproportionate amounts of poor treatment, including verbal abuse and physical abuse. And then again, the literature is ripe in the consequences of, again, unequal treatment. A report from the Academy, less literature in the nursing arena, but we know that is rampant. So when we also thinking about individual impact, which I think is, again, the majority of what we're going to be discussing today, is what is it that we do at the point of care? How is it that we address social determinants? And how do we address social needs for everyone as well as for complex patients? And again, we have a number of strategies to be able to do that. When we think of social determinants of health, here is a definition. It's conditions in which people are born, grow, live, work, and age that are shaped by the distribution of money, power, and resources at global, national, and local levels. It's important to understand that social determinants of health just don't affect vulnerable populations. They affect all of us, and we have the responsibility at the point of care to at least assess and to understand how all of those factors determine our health behaviors and health outcomes. So I think a useful definition when we think about addressing social needs at the point of care, again, this is not new. Our colleagues in the UK have been doing this for years. They call it social prescribing. There really are two different areas that we should consider. The first one is social needs or informed care, and those are activities that involve modifications to traditional health care to account for patients' social circumstances. So when we think about how do we provide transportation to people to make their appointments, how is it that we use translators, assessing for data on food access, those are things that, again, involve modifications to what we do. But there's also social needs and targeted care, and that is how do we address activities in clinical settings that address the social needs such as income assistance, housing, and food supports at the intersection of care. What I want to say is that nurses do this extremely well, and we have many evidence-based programs. The Edge Runners are a fabulous example of evidence-based examples that improve patient care that are economically feasible. And here is just a spattering of some of the Edge Runner models that, again, are across all settings: school setting, community settings, healthcare settings, and across all age spectrums. When there's a group of us, Grant Martsolf, Diana Mason, and myself, did a deep dive into the Edge Runner models because we were curious. We have always said, as RWJ came out with the culture of care, this is nothing new for nursing. We've been doing this since the time of Florence Nightingale. And so we really wanted to take a look at these evidence-based models to see how, in fact, they addressed a culture of health. And so again, what we saw here that you see on the left hand is evidence that we address the social needs in terms of modifying health care. So looking at increased access to health care through a variety of methods, through transportation, through cultural appropriate materials, through helping people navigate once they're in the health system. But we also address issues that again, housing, transportation, and we do that by fostering cross-sector collaborations, working with community needs, communication with stakeholders. So we have evidence not only that these work, but I would say work towards health equity. The issue with many evidence-based nursing innovations is that we have issues in terms of the scale-up and the spread of these. And so recently, we convened a group here looking at the needs of elders and how to best account for chronic complex illnesses and what would be needed to scale up nursing interventions. And we had a group of healthcare system leaders who dealt with elders, not just nurses. And the conclusion was that we have to foster system-level infrastructure that leverages the contribution of nurses for current and emerging roles. Now, while this was applied to the elderly, you can say this about any evidence-based program that we have, and that we need to work and pay attention to how to accelerate the adoption or adaptation of evidence-based intervention. In another study that was done by Penn Nursing and BDO, we surveyed a group of healthcare system leaders and economic leaders, and they identified the current challenges in the healthcare system that A, healthcare leaders saw, and B, that businesses were willing to invest in. And so you can see the areas that are in this overlapping circle here. It's chronic care coordination, it's mental health, it's innovation, it's population health. Again, an area where nurses excel. And while people recognize that nurses have the expertise, only 44% of these healthcare systems had nurses that were in the C-suite. So how are we going to scale up these interventions in whatever setting we're at if we don't have nurses at the leadership table? So recommendations that came from that was that we have to remove barriers that discourage nurses from practicing to their full scope, not just at state level, but in institution levels. We have to create organizational structures and incentives that support innovation, and we have to elevate at least one nursing leader to the C-suite. So the next stage is probably the most complicated stage and probably one that we spend less time talking about, and that is what happens at the community impact. One of the big drivers around disparities and achieving health equity is structural racism. It means that we have to work at improving community conditions, and the way that we do that is through laws, policies, and regulations. So a definition of structural racism is a system in which public policies, practices, and norms work in various and often reinforcing ways to perpetuate racial group inequity. And you can say racial, you can say gender, you can say there's a number of inequities. The US is really good at doing this. I mean, it is absolutely part of our history. As the banner in the middle says, racism is as American as baseball. We have the history of slavery. We have the Trail of Tears from the Native American Indians. We have the Chinese Immigration Act that worked to suppress and send Chinese immigrants who were here for the railroads. We have migrant workers, the immigrants from Mexico, Central America. We have women's issues. We have gay issues. So again, this is absolutely part of our fabric, and we have to recognize that. It's naive of us to think that this doesn't impact, I don't know why I'm having so much trouble here, doesn't affect healthcare. And so we have many examples in healthcare where some of those greater laws have impacted what we have been able to do and what we do at the point of care. From forced sterilization to lack of access to women's health care, to the discrimination and disparity around psychiatric disorders and LGBTQ health. So in order for us to move forward, we have to be able to work at all levels. We can't just work at clinical care. And again, I have some good exemplars of people and situations that nurses have led or have participated in. So we take the example of breastfeeding. We all know how important breastfeeding is to child development, yet only 20% of infants are exclusively breastfed for the first 6 months. So we have a number of clinical solutions that we do at the point of care, one by one of our faculty, Diane Spatz, who is a 10-step model that has increased breastfeeding phenomenally, and there are other similar type models that are clinical solutions. Again, we need the support of healthcare systems to make sure that that's part of the fabric, and importantly, because people don't stay in hospitals for 2 years to breastfeed their babies, we need to make sure that there are systems and supports outside, such as portable breastfeeding units. Firearm violence is another issue that's affecting us. We know that there's a disproportionate burden of gun violence around African American communities, and that can be traced in our city of Philadelphia to redlining that happened in the 1930s. So again, you can see the redlining districts here, and you can see the incidence of violence. So we can think of clinical solutions about how to treat. We can talk about healthcare system solutions, about how we help transition our patients back into the community, but we really need policy solutions to be able to address this. Firearm violence has to be a public health crisis, not a criminal justice component, and we really need to be investing in these communities in order to mitigate the violence. As another example, we know cardiovascular health is a problem, specifically around African American males who experience a disproportionate of hypertension-related morbidity and mortality. We also know that black men are disproportionately imprisoned and in jail. You know, they're not, we just know that that's true. And we also know that at the intersection that black men who have been imprisoned or incarcerated have a 12-fold increased risk of death in the first 2 weeks after release, with cardiovascular disease among that. So what to do? Yes, we have our clinical solutions. We have the behavior modification components. But a group of faculty here at Penn, including our own Lisa Lewis, who is a nurse here, is working with the criminal justice system to work on a diversion program for first-time offenders to keep them out of prison. And again, health was not the primary component here, but it's one that we've injected here, because the long-term policy solution is, again, criminal justice reform, alternatives to jail, and diversion program. Migrant workers is a particular issue as well, and when we're taking a look at even the legal-related issues, access to health care is an important component. I have 30 seconds. Move on. So the bottom line is we can't exist on the counseling and clinical interventions here. We have to work on the policy solutions. That's the trickle down. It's not enough for us to work on implicit bias. We have to work on the structural racism. I should get some more seconds because of the clicker here. So here are, again, issues that I think we need to move forward. Structural oppression is not new. We have a strong imperative to push back. Health equity can't be focused on clinical care. We need to work with legal structures. We have to shift our priorities to work on all fronts. I'm saying here we have a number of nurse champions, both past, the present, and our future engagement prize winners, who Marcus can tell you about, who are doing fabulous work and leading the way in that area. I have some considerations for the committee that you can read later because you'll have my slide set. And I will close with this from Langston Hughes, who says, out of the rack and ruin of our gangster death, the rape and rot of graft and stealth and lies, we the people must redeem the land, the mines, the plants, the rivers, the mountains, and the endless plain, all the stretch of these great states, and make America again. So thank you. Is on. So now it gives me great pleasure to introduce this distinguished panel here. You have seen their extensive bios online, so my apologies for the shortened component. But first we're going to hear from Erin Graham, who is a nurse supervisor with the National Nurse-Led Care Consortium, who will discuss maternal child health. Robin Cogan, who is a school nurse from the Camden City School District, will discuss school health. We have the president and CEO of the Pennsylvania Association of Community Health Centers, Sherry Reinhardt, who will discuss rural health. And Alicia Georges, the chair of the Department of Nursing at Lehman College, and also, what's your title at AARP? President of AARP, volunteer president at AARP. So with that, Erin.